Welcome back to the deep dive. You've brought us a pretty dense stack of sources today.
It is, yes. We're looking at clinical reviews, epidemiological studies, a whole range of material.
And it's all focused on one condition, a condition that has really been at the center of one of the greatest medical paradigm shifts in the last century.
It really has. Today, we are diving deep into peptic ulcer disease, or PUD. And this isn't some historical footnote. It's still a global condition that affects up to 1 in 10 people at some point in their life.
1 in 10, that's a huge number.
It is. And the story of PUD, I think, is a fantastic medical detective story. It evolved from a disease we blamed on, high-strung personalities or spicy food.
Right, the classic trope. The overworked executive living on black coffee and chili gets an ulcer.
Exactly that. And now we know it's rooted in microbiology and pharmacology.
Okay, so let's unpack this. Our mission today, and we're drawing solely from the material you've brought, is to cut through all of that mythology. We're going to get into the exact pathogenesis, the surprising etiology, and those clinical signs that really tell you what's going on.
Precisely. And we're keeping the focus tight. We're looking at the causes and the presentation. We're going to set aside the whole complex world of investigations and management, all the drugs, the endoscopies. That's for another day, perhaps.
So if you're listening to this, maybe prepping for a case or just trying to get your head around the condition, this is about the what and the how. What is it and how does it start?
That's the goal.
And to do that, we have to start with a really clear, non-negotiable definition. Because I think a lot of people confuse PUD with, simple heartburn or a bit of stomach irritation.
A very common confusion.
So what does a lesion structurally have to do to be called a true peptic ulcer?
It's all about depth. The definition is a discontinuation in the inner lining of the GI tract. We're usually talking about the stomach and the proximal duodenum, caused by gastric acid or pepsin. But here's the crucial part.
Okay.
The part that separates a real ulcer from a simple erosion is that the damage must extend all the way into the muscularis propria layer.
The muscularis propria, that's the deep muscle layer of the stomach wall, isn't it?
It is, and that detail is absolutely vital. We're not talking about a little scratch on the surface. We're talking about a wound that is punched through the protective layers, through the supporting structures, and deep into the actual muscle of the wall.
That distinction is everything. An erosion, then, is just superficial.
Exactly. And erosion is limited to that top mucosal layer. It usually heals quite quickly. It rarely causes major problems. But an ulcer, because it reaches the muscularis propria, it carries an exponentially higher risk of, catastrophic complications.
Like what?
Like life-threatening bleeding if it hits an artery in that muscle layer, or actual perforation where the acid just burns a hole right through the entire wall and spills into the abdominal cavity. The depth really does determine the danger.
Which makes that huge shift in medical thinking even more incredible. You have this deep, dangerous wound, and for decades, the best guess was anxiety.
It seems unbelievable now, doesn't it?
It really does, because the sources just dropped this bombshell right at the start. The vast majority of PUD is because of just two things: Helicobacter pylori infection and the use of NSAIDs.
It's a profound paradigm shift. I mean, the sheer magnitude of that change moving from some vague psychosocial cause to a specific bacterium and a class of drugs, it has completely revolutionized treatment across the globe.
The stomach is designed to handle this incredible acid, so it must take something very specific, like a specialized bacterial attack or a drug that shuts down the defenses to let that acid through.
That's it in a nutshell.
And before we get into the nitty-gritty of how all that works, I want to give you, the listener, the immediate clinical takeaway, the single biggest clue that helps separate a gastric ulcer from a duodenal one, just from talking to a patient. And it's all about the timing of the pain relative to meals.
Yes.
So keep that idea locked in your mind, because it's the foundation for everything we're about to build.
All right, let's start with the geography of the gut. If you're going to understand PUD, you need to know where these deep wounds are most likely to show up.
Location is absolutely key. The PUD landscape is surprisingly localized.
So we know it's generally the stomach and the proximal duodenum, that first little bit of the small intestine.
And of the main territory, yes. The C-shaped segment right after the stomach. But the sources do mention some outliers. You can, in rare cases, see ulcers in the lower esophagus or further down in the distal duodenum, even the jejunum.
But that's not typical.
Not at all. That's usually in the context of some kind of hypersecretory condition, which we'll touch on later. Unusual diseases causing way too much acid. So let's focus on that main battleground. Within the stomach and the duodenum, are there specific anatomical hotspots? Are some areas more vulnerable than others?
Oh, very much so. Histopathology has identified two very specific danger zones.
Mm,
For gastric ulcers, the ones in the stomach, the vast majority are found on the lesser curvature.
the lesser curvature, why there?
Well, it's about the anatomy and the flow of acid. Think of it like a riverbed. The gastric acid tends to flow along this channel on the inside curve of the stomach. So that area, the lesser curvature, just gets continuous, prolonged exposure. It's the prime target.
A river of acid carving out a canyon.
A good way to put it.
And what about the duodenum? We already know it's the more common location overall.
Yes, and duodenal ulcers are overwhelmingly concentrated in one specific spot. The duodenal bulb. This is the immediate section of the small intestine that receives that acidic slurry, the chyme, from the stomach.
So it's the first thing to get hit.
It's the absolute front line. And here's a really striking fact from the sources. Duodenal ulcers are 4 times more common than gastric ulcers.
4 times.
4 times. That asymmetry tells you something really important. It tells you that while the stomach lining is pretty well adapted to its own acid, that initial segment of the small intestine, the duodenal bulb, is the system's real weak link, especially when its protective mechanisms are shot.
That number is just staggering. It immediately makes you focus on that transition point, how the stomach contents move into the intestine. Now, physically, what do these things look like? What's the morphology?
The sources describe a pretty classic appearance. The ulcer is usually round or oval, and it has a relatively smooth base. You can often tell if it's new or old just by looking at the edges.
Oh, so?
An acute ulcer one that's developed pretty rapidly, it tends to have these very regular, clean, well-defined borders. A chronic ulcer, on the other hand, one that's been there for a while, often has elevated, sometimes thickened borders with a lot of inflammation around it.
But the key is always the depth.
Always. Regardless of how it looks on the surface, the defining feature is that the lesion extends beyond the muscularis mucosa. That's the line in the sand.
And that structural depth is what we keep coming back to because it drives the clinical severity.
Precisely. Let's connect that depth back to the symptoms. If that ulcer is deep enough to chew through a major artery sitting in that muscle layer,
You get a massive GI bleed.
a massive, potentially fatal GI bleed. And if it goes all the way through the wall, you get perforation and peritonitis, a sudden life-threatening abdominal infection. The physical depth is literally the difference between chronic pain and an emergency trip to the operating room.
Which leads us perfectly back to that most valuable diagnostic clue you mentioned, the pain timeline. Let's really map this out for the listener because it's such a critical distinction between gastric ulcers, GU, and duodenal ulcers, DU.
Let's do it. Let's start with the gastric ulcer. So remember, the GU is inside the stomach, usually on that lesser curvature.
Right.
So a patient eats a meal. The stomach's immediate response is to ramp up acid and pepsin production to start digestion. And the source material is very clear. The epigastric pain kicks in quickly, usually within 15 to 30 minutes of eating.
So food goes in, the acid production switch flips on, and that acid immediately washes over the raw wound. It's an immediate, predictable, and painful response.
You got it. The food itself might briefly act as a buffer, but its very presence stimulates the production of the very thing that's causing the pain.
Okay, now contrast that with the duodenal ulcer.
A completely different story.
Yeah.
The duodenal bulb isn't hit by that acid right away. It takes time for the stomach to do its work, to break down the food and release the chyme through the pyloric sphincter into the duodenum.
So the pain is delayed.
Exactly. The classic clinical picture is pain that starts 2 to 3 hours after a meal.
So you eat, you feel fine for a bit, maybe even better because the food is buffering the acid in your stomach.
Yes, often there's a period of relief.
But then as the stomach empties its acidic contents, that buffer is gone and the raw duodenal bulb is suddenly hit with this massive corrosive load, and that's when the pain hits.
Perfectly described.
Yeah.
And we absolutely must mention nocturnal pain here.
The pain that wakes you up at night.
Yes, and this is highly characteristic of duodenal ulcers specifically. Even when you're fasting overnight, your stomach is still secreting basal levels of acid. When your stomach is empty, there's nothing there to buffer it, and even that low level of acid is enough to continuously irritate the raw duodenal bulb. Many patients with DU will tell you they wake up in pain between midnight and 3 a.m.
That distinction is just so powerful. If you just know the patient's pain schedule relative to their meals, you have a very, very high chance of knowing where the ulcer is.
It's a fantastic piece of clinical detective work.
Okay, so Beyond that crucial pain timing, what about the other common signs and symptoms, the general picture of PED?
Well, the primary complaint is, of course, that epigastric abdominal pain, right, in the upper abdomen. But there are other important signs related to how the digestive system is functioning.
Like bloating and abdominal fullness. And the sources specifically link this to something called gastric outlet obstruction.
Yes, this is a serious complication. Gastric outlet obstruction happens when the swelling, or more often the scarring, from a chronic ulcer, usually one right near the pylorus, the stomach's exit, physically blocks that exit.
So food and liquid get trapped in the stomach.
They can't pass efficiently. This leads to that persistent fullness, that distension, and very often nausea and vomiting. Sometimes vomiting can actually provide a bit of temporary relief because it empties the distended stomach.
Now, what about weight changes? This was interesting. The sources say it's variable. Some people lose weight, but some can actually gain weight.
It's a fascinating detail, and it likely comes back to the type of ulcer and the pain timeline we just discussed.
How so?
Well, think about the patient with a gastric ulcer. Their pain starts almost immediately after eating. So they learn to associate food with pain. What do?
They stop eating or eat less, so they lose weight.
Exactly. Now think about the duodenal ulcer patient. Their pain is delayed. In fact, eating a meal temporarily relieves their pain because the food buffers the acid. So what might they learn to do?
They learn to eat more frequently to keep the pain at bay, and that could cause weight gain.
It's a wonderful clinical insight, isn't it? It's not just a random symptom. It's a behavioral response driven by the underlying pathophysiology.
It really is. And finally, we have to touch on the most serious signs, the signs of bleeding.
Yes. Because the ulcer reaches the muscularis propria, that vascular-rich layer, the risk of erosion into a blood vessel is high. So we have to look for hematemesis, which is vomiting blood, either bright red or looking like coffee grounds, and melena.
Melena being the dark, tarry stools.
Correct. Which is the result of digested blood coming from the upper GI tract. These are the immediate urgent signals that the depth of that ulcer has crossed a line and has become potentially life-threatening. Okay, so now we transition. We've defined the damage. Now we need to identify the culprits. And as we said at the top, this is fundamentally a story of an imbalance, and the primary antagonist, the one that rewrote the medical textbooks, is the bacterium Helicobacter pylori.
Let's just get the overview straight. We know it's the dominant cause, but the numbers really just drive the point home.
They're staggering. The sources are clear. H. pylori is responsible for an overwhelming 90% of all duodenal ulcers.
90%.
90. And a very substantial 70% to 90% of gastric ulcers. The take-home message is, if you come across a patient with a duodenal ulcer, your default assumption has to be H. pylori infection until it's proven otherwise.
It's unbelievable. It elevates this organism from just an interesting microbe to a central public health factor. So let's get a profile on this little menace. What is H. pylori?
It's a gram-negative bacillus, but its habitat is the crucial detail here. It doesn't just, float around freely in the stomach acid. It is found within the gastric epithelial cells, often tucked away right underneath the protective layer of mucus. It's a highly specialized colonizer.
And the epidemiology around it is fascinating. The sources say it's highly prevalent in lower socioeconomic groups, and it's usually acquired during childhood.
Yes, which suggests a strong link to sanitation and hygiene conditions early in life. This isn't usually something you catch as an adult. It's often acquired as a child, and then it can just sit there, sometimes dormant, sometimes causing a low-grade chronic inflammation for decades before an ulcer ever develops.
And the reason it's so successful, the reason it can survive and cause all this damage, is down to its toolkit, its virulence factors. This is where it gets really interesting. How does a bacterium survive in one of the most acidic environments in the known biological world?
It seems like an impossible task, doesn't it? The stomach's pH is designed to sterilize everything.
It should be a death sentence for a bacterium.
Well, it gets around it through some specialized biochemical genius. The first and most critical virulence factor is an enzyme called urease.
Urease.
The sources explain its function very clearly. H. pylori pumps out massive amounts of this enzyme, urease, which takes urea waste product that's naturally present in our gastric secretions and breaks it down into carbon dioxide and, crucially, ammonia.
And ammonia is strongly alkaline. It's a base. So the organism is essentially creating its own personal force field.
Precisely. We often call it the ammonia cloud. This local production of ammonia rapidly neutralizes the intense stomach acid in the immediate vicinity of the bacterium. This allows it to colonize the stomach lining without being dissolved. Without urease, H. pylori simply couldn't survive in the human stomach. It is the absolute key to colonization.
That is a stunning piece of bioengineering. Okay, so that's survival. What else is in the toolkit that lets it attack?
Next up, we have its specialized toxins. The two major players here are Kage, that's cytotoxin-associated gene A, and Vakai, vacuolating cytotoxin A.
And these are the weapons.
These are the agents of war.
Hmm?
The sources confirm that these toxins are associated with profound mucosal inflammation. They disrupt the host cell's internal machinery, they cause direct tissue damage, and they lead to cell death or detachment from the stomach lining.
So Urease keeps them alive, the toxins start the fight, we have survival and destruction. What about getting around that thick, viscous mucus?
That's the third critical factor, flagella. H. pylori is a motile bolus. It's equipped with multiple flagellas, which are like little corkscrew tails.
So it can swim.
It can swim, yes. It gives us this corkscrew motility, which is essential for it to move through that thick mucus layer. It allows the organism to travel down from the harsh, high-acid environment of the stomach lumen, penetrate the mucus, and get right up against the epithelial cells where the pH is a bit more neutral and it can adhere more easily.
Wow. That combination, survival, mobility, and destruction, it's just terrifyingly effective. But let's trace the full mechanism. How does all of this, over time, lead to an ulcer that's deep enough to breach the muscularis propria?
Right. This is where it gets a little complex, and it actually addresses a paradox. The colonization and the chronic inflammation that these virulence factors cause have a cascade effect. Interestingly, in some cases, H. pylori colonization can initially lead to hypochlorhydria or even achlorhydria.
Wait, decreased or absent acid production?
Yes, because the inflammation can damage the acid-producing parietal cells.
But hold on, if the acid is lower, how does that cause an ulcer? That seems to completely contradict the idea that PUD is an acid-driven disease.
And that's the brilliance of its complexity. While the acid might be suppressed in some parts of the stomach, that chronic inflammatory state is simultaneously destroying the protective architecture of the mucosa. The sources highlight this dual effect. H. pylori colonization and inflammation, especially in the antrum, the lower part of the stomach, it severely impairs the secretion of bicarbonate and mucus.
Ah, okay. So bicarbonate is the body's own natural antacid, and mucus is the physical barrier.
Exactly. So even if the overall acid production is a bit lower, the protective layers are far, far more compromised. And it gets even more complex with duodenal ulcers, which, remember, are 90% caused by H. pylori. The organism doesn't usually colonize the duodenum itself.
So how does it cause the damage there?
The inflammation it causes in the stomach actually leads to increased gastrin secretion, which in turn leads to increased acid output from other parts of the stomach. That superacidic load then gets dumped into the unprepared duodenal bulb and overwhelms it.
So for duodenal ulcers, the H. pylori in the stomach is like a remote control that cranks up the acid production, while at the same time it's crippling the host's ability to defend the duodenum with bicarbonate.
Precisely. The bacterium even promotes something called gastric metaplasia, where the duodenal cells start to change and resemble stomach cells, which then makes them vulnerable to colonization. So the failure is systemic. Whether it's through direct damage from toxins or crippling bicarbonate secretion or indirectly overstimulating acid, the net result is always the same. A failure of the protective system, which allows the corrosive forces to penetrate deep and create that defining ulcer.
Okay, so moving on from that microbial mastermind, we have to talk about the second major cause. And this is something that's sitting in virtually every household medicine cabinet in the country. NSAIDs.
Non-steroidal anti-inflammatory drugs.
Yes.
Yeah, this is a great drug dilemma, a classic case of pharmacological interference that just shuts down the body's own defenses.
And this is the undeniable number 2 cause, right after H. pylori.
Absolutely. Second only to H. pylori infection. And when you think about how widespread these drugs are, I mean, for everything from a headache to chronic arthritis, the sheer scale of PD associated with them is just vast.
And the mechanism is purely pharmacological. It's a clean contrast to the bacterial invasion we just covered. Let's get into the prostaglandin story, because that's really the heart of how NSAIDs cause this damage.
To understand the damage, you have to first appreciate what prostaglandins normally do in the stomach. These are natural, hormone-like lipids that the body makes. And in the GI tract, their role is almost entirely protective. They are the gastric support staff.
So what do they do specifically?
They promote robust gastric mucus production, they increase bicarbonate secretion, and they ensure there's adequate mucosal blood flow. Those are the 3 pillars of gastric defense.
Mucus, bicarbonate, and blood flow. Okay, so when a patient takes an NSAID, maybe for an inflamed knee, what is happening in their stomach to these protective factors?
The interference is direct and it's aggressive. NSAIDs work by blocking the synthesis of prostaglandins throughout the body. They do this by inhibiting an enzyme called cyclooxygenase 1, or KOX1. And KOX1 is what we call the constitutive or housekeeping enzyme that's responsible for producing those essential protective prostaglandins in the stomach lining.
So by taking a high dose of, say, ibuprofen, you are effectively turning off the production line for your stomach's armor. It's a self-inflicted vulnerability.
That is precisely it. The resulting damage is a powerful trifecta. You inhibit COX1, and the consequences are immediate. You get a significant decrease in gastric mucus production, so you're stripping away the physical shield. You get a decrease in bicarbonate production, so you're removing the chemical neutralizer. And critically, you get a decrease in mucosal blood flow.
Which means the lining can't repair itself properly.
Exactly. It hinders the ability of the cells to heal and to clear away damaging waste products. The damage isn't just chemical, it becomes ischemic as well. You've compromised the stomach's ability to defend itself, to neutralize acid, and to heal itself.
And given that the stomach is always a corrosive environment, once those defenses fail, it's really only a matter of time before the acid and pepsin breach that deep muscular layer.
And this brings us right to the core concept that ties both H. pylori and NSAIDs together. This is the one thing we need the listener to really take away from all this.
The central imbalance.
PUD is fundamentally an imbalance between two opposing sets of forces.
Okay, let's break that down. First, the protective factors. These are the good guys, the defense forces that are either impaired by the bacteria or shut down by the drugs.
Those are, as we said, the robust mucus layer, a physical shield, the bicarbonate secretion, the chemical neutralizer, and the ample mucosal blood flow, which is the repair and maintenance crew. If any one of these falters, the whole system is weakened.
And on the other side of the scale, we have the destructive factors, the enemies that are always present but only become a problem when the defenses fail.
Primarily gastric acid, which is produced by the parietal cells, and pepsin, a very potent digestive enzyme that's activated by acid. The entire mechanism of PUD, regardless of the initial cause, is that simple. When the destructive factors overwhelm the protective factors, you get a localized breach that goes deep. It's almost always a failure of defense, not necessarily a massive overproduction of acid.
Which is what makes H. pylori and NSAIDs such perfect villains. They don't have to bring their own army, they just have to open the castle gates for the enemy that's already inside.
A perfect analogy.
So if you're a listener trying to think about risk profiles, what are the known factors that predispose someone to this imbalance? The sources list several key ones.
Well, the top two are obvious: H. pylori infection and chronic NSAID use. Beyond that, there's a definite familial link. Having a first-degree relative with PU is a known predisposing factor.
Which suggests a genetic component.
It does. Perhaps it's related to differences in how robust someone's mucosal lining is, or their healing rates, or even their specific immune response to H. pylori.
The sources also list some really interesting epidemiological factors. African American and Hispanic ethnicity are listed as risk factors, and so is being an immigrant from a developed nation.
Yes, and the context here is crucial. For African American and Hispanic populations, this often points towards historical differences in early life exposure to H. pylori due to various socioeconomic or environmental patterns leading to higher carriage rates in those communities. It's not necessarily a direct genetic vulnerability in all cases.
And the immigrant from a developed nation, that seems counterintuitive.
It does, but it's likely also linked to hygiene and exposure. Someone moving from a highly sanitary environment might encounter H. pylori for the first time later in life when their immune system reacts differently. Or a change in environment, diet, or stress could trigger a latent infection that was acquired years ago. These aren't just random facts. They're markers of systemic differences in colonization and vulnerability.
So we've covered the big two, the culprits responsible for, 9 out of 10 cases of PU? But PU is a complex endpoint, and we need to talk about the less common but often very serious secondary triggers, the things that can cause ulcers even without H. pylori or NSAIDs in the picture.
This is vital, especially when you see ulcers that are resistant to standard treatment or show up in unusual locations. We have to first look at other medications and certain lifestyle factors that can compromise that protective barrier.
Okay, so beyond NSAIDs, what other drugs should be on our radar?
The sources implicate several other common drug classes, corticosteroids, for example. They are well known to slow down the healing process and compromise the immune response, which makes the mucosa much more vulnerable to any existing damage.
And what else?
Bisphosphonates, which are used for osteoporosis, and potassium chloride supplements. These are often implicated because of their direct local irritant effect. If a pill sits against the gastric mucosa for too long, it can cause a sort of chemical burn.
A contact injury. That makes sense.
And then there are certain chemotherapy agents, like fluorosil. These drugs are designed to kill rapidly dividing cells, which unfortunately includes the cells that line our gastric mucosa and are constantly regenerating. So it directly undermines the body's ability to repair itself.
Now, what about those lifestyle factors? The things that used to get all the blame before we knew about H. pylori? Smoking and alcohol.
They still play a measurable, though secondary, role. The sources confirm that smoking has a particularly aggravating effect, especially on duodenal ulcers. It doesn't usually cause an ulcer on its own, but what it does is significantly impair mucosal blood flow through vasoconstriction.
So it strangles the blood supply needed for healing.
Precisely. It makes existing ulcers heal much more slowly and makes them more likely to come back. And as for alcohol, its impact is really twofold. It can be a direct irritant to the mucosa, but more significantly, it stimulates gastrin release, which induces more acidity. It shifts that balance firmly towards destruction.
So they're not the root cause, but they're accelerants.
That's a very good way to put it.
Okay, let's shift to the really dramatic, though rare, situations. The hypersecretory environments where the body itself just goes into acid production overdrive.
Yes, these are conditions where the sheer volume of acid is so overwhelming that it can burn through even a healthy, intact protective barrier.
And these are critical to recognize because the ulcer is often just the first symptom of a much bigger systemic disease.
Exactly. The most famous example, which the sources list, is Zollinger-Ellison syndrome, or ZES.
And ZES involves tumors called gastronomas. Right?
Correct. Tumors, usually in the pancreas or duodenum, that continuously pump out massive, unregulated levels of the hormone gastrin. And gastrin's only job is to tell the parietal cells to make acid.
So it's like the accelerator pedal is stuck to the floor.
Completely. The gastrin levels are so high, the acid production is so relentless, that patients often present with multiple treatment-resistant ulcers, sometimes in very unusual places like the jejunum, far beyond the normal duodenal bulb.
That must be incredibly destructive. What are some of the other hypersecretory states the sources mention?
There is systemic mastocytosis, where an overabundance of mast cells releases excessive histamine, and histamine is another potent trigger for acid secretion. We also see hyperparathyroidism listed and antral G cell hyperplasia, which is an overgrowth of those gastrin-producing cells right in the stomach lining itself. Even cystic fibrosis is mentioned, often due to abnormal bicarbonate handling.
It's a sobering reminder that while bacteria and drugs are the usual suspects, sometimes the body's own machinery can just go haywire.
It can. And finally, we should just briefly run through the remaining truly rare causes. These are important for a complete differential diagnosis.
So what's on that final list?
Malignancy, gastric cancer, lung cancer, lymphomas. A deep ulcer that refuses to heal, especially in the stomach, must always raise the suspicion of an underlying cancer.
Then there's stress. But this isn't the emotional stress we debunked earlier.
No, this is acute, severe physiological stress. The kind you see with extensive burns, we call those Curling's ulcers, or a major head injury, which can cause Cushing's ulcers. It's all about systemic shock and compromised blood flow to the gut.
So the stress is about ischemia, not deadlines.
Exactly. The list finishes with things like viral infections, CMV, or herpes, usually in immunocompromised patients, vascular insufficiency, radiation therapy, and even Crohn's disease. The common thread in all these rare causes is a fundamental compromise of the blood supply, the structural integrity, or the healing capacity of the gut lining. So let's pivot now. Let's look at PUD from a much broader perspective. Let's talk about the epidemiology, the global picture, and what that tells us about this condition.
And what stands out here is this massive scale of the problem, but it's balanced against a really positive trend, isn't it?
It is. Peptic ulcer disease is still a huge public health issue. The lifetime risk of developing it is somewhere between 5% and 10% worldwide. That's millions and millions of people.
But the good news, which is a major victory for modern medicine, is that the overall incidence is actually decreasing globally. So why are we winning this fight?
The sources point directly to the things we've been discussing. The decline is attributed to, 1, improved hygienic and sanitary conditions, which reduces how often children get H. pylori in the first place.
Right.
2, effective screening and targeted antibiotic therapies to eradicate the bug when we find it. And 3, a much more judicious use of NSAIDs, including the development of newer drugs like KIOX2 inhibitors that spare that protective KIOX1 enzyme in the stomach.
That link between public hygiene and PUD incidence is such a huge insight. If we're getting better at preventing kids from getting H. pylori through clean water and sanitation, we're cutting off the root cause for 90% of duodenal ulcers decades before they even have a chance to develop.
It is a public health triumph. It's the ultimate confirmation that this is a disease of exposure and defense failure, not a disease of personality. And just to cement that data point we touched on earlier, duodenal ulcers are still 4 times more common than gastric ones, and DUs are still statistically more common in men than in women.
So men are disproportionately affected by the most common form of PUD. Okay, so connecting all this back to the clinic, what does this mean for how PUD is actually handled today?
Well, our modern understanding of the cause dictates the entire diagnostic approach. The sources are very clear. Testing for H. pylori is recommended in every single patient who presents with PUD symptoms. You have to treat the microbe, not just the acid.
And if that test comes back positive,
The management strategy follows directly. Today, most patients are managed with what we call a PPI-based triple drug therapy. That's a proton pump inhibitor to dramatically cut down the acid, combined with 2 different antibiotics to make sure we completely eradicate the H. pylori.
and that approach has been a game changer.
It's transformed the prognosis from a chronic, recurring problem to something that is, for most people, a near total cure.
Now, we said we're skipping deep investigation methods, but the sources do emphasize that sometimes you have to take a look inside. When is an endoscopy required?
Endoscopy might be needed to confirm a diagnosis or to check on healing, but most importantly, it's required in patients who present with what the sources call sinister symptoms. We call them the alarm bells.
Alarm bells.
Yes. When these symptoms are present, the risk of something much more serious, like a malignancy or a severe complication, goes way up, and we have to investigate immediately.
Okay, this is the crucial practical application for anyone listening. These are the red flags, the crucial warning symptoms that mean this is not a simple case. What are they?
The first one to watch for is unintentional weight loss. Any significant unexplained drop in weight combined with chronic epigastric pain has to be taken seriously. It raises the suspicion for an underlying cancer, like gastric cancer, or a very severe ongoing inflammatory problem.
What's next?
Progressive dysphagia. That's difficulty swallowing that gets worse over time. This is a huge red flag that inflammation or scarring is causing a blockage, or perhaps a mass is growing near the top of the stomach.
Then there's the obvious one, overt gastrointestinal bleeding. Vomiting blood or passing melena, that's an emergency.
It is. But sometimes the bleeding is slower, more chronic. And that's where we see iron deficiency anemia. A persistent, unexplained anemia is a sign that the patient has been slowly losing small amounts of blood for weeks or months from a smoldering ulcer.
And the final 2 are often linked to obstruction or cancer risk.
Correct. Recurrent emesis or persistent vomiting, which strongly suggests that the gastric outlet is blocked. And a strong family history of upper gastrointestinal malignancy. Given the potential genetic links we discussed, that family history always raises the level of suspicion.
So these alarm bells really shift the clinical picture from a manageable chronic issue to a potential emergency.
They do. The framework is simple. The pain timing helps you figure out what the ulcer might be. Stomach versus duodenum. The alarm bells tell you how serious the underlying problem might be. Simple ulcer versus something much worse.
So let's try and synthesize all of this. We set out to decode peptic ulcer disease, and the source materials has really given us this unified modern story. PD is a battle, but it's not a battle against anxiety or spicy food. It's a failure of the body's protective prostaglandin layer.
A failure that is almost always caused by one of 2 things.
Yeah.
The microbial assault of H. pylori or the pharmacological shutdown caused by NSAIDs.
We established that the damage is deep. It has to go into the muscularis propria, which is what explains the risk of serious complications. And we clarified the geographical hotspots, the lesser curvature for gastric ulcers, and that highly vulnerable duodenal bulb for the vast majority of cases.
And for you, the learner, we have 2 absolutely critical, clinically relevant takeaways.
The first has to be mastering that distinction in pain timing. Gastric ulcer pain is fast, 15 to 30 minutes after a meal, as the acid washes right over the wound.
And duodenal ulcer pain is delayed, 2 to 3 hours post-meal or waking the patient up at night after that food buffer is gone.
The second takeaway is to remember the specific mechanisms of the 2 main culprits. For H. pylori, it's that triple threat.
Urease creating the ammonia shield to survive. flagella giving it motility to get through the mucus, and toxins to cause inflammation and direct tissue damage.
And for NSAIDs, it's the pharmacological sabotage. They inhibit the COX-1 enzyme, and in doing so, they systematically demolish those three pillars of defense: the mucus barrier, the bicarbonate neutralization, and the mucosal blood flow needed for healing.
And if we just connect this to the bigger picture for a final thought,
Mm-hmm.
the sources make it so clear that the global decline in PUD is directly linked to better hygiene and sanitation. That success story forces us to reconsider other diseases.
Which raises a really important question for you to think about in the coming days. How many other chronic common conditions, things we traditionally blame on lifestyle or genetics or autoimmunity, how many of them are actually at their core a battle against a low-level, persistent bacterial, viral, or environmental factor that we're only now starting to control through public health improvements?
That shift in thinking, from blaming the patient's personality to tracking the patient's microbes, that is arguably the single defining medical lesson of peptic ulcer disease.
A powerful thought that goes far beyond just gastroenterology. Thank you for diving deep with us today.
My pleasure.
We'll catch you on the next deep dive.